Welcome to Trifecta Collective, Finding the Root, where we dive deep into understanding and addressing root causes of chronic health issues so you can help and find healing inside and out, now and forever.
Hello, and welcome to Trifecta Collective, Finding the Root. I'm Megan Abbott, owner and founder of the holistic health practice Trifecta Collective. Welcome to the podcast. So today we are hopefully going to wrap up How Do You Know You're Going into Perimenopause, Part 3. And in this episode, I really want to talk about what hormones actually do for our body before, during, and after perimenopause, and why it's so important that we really keep an eye on these and the long-term impacts, risks, consequences of not supporting our bodies when it comes to hormones. So today I'm going to go through estrogen, progesterone, and then testosterone, what these things do to our body. What else do they help with outside of just reproduction? Because I really don't think most of us really understand the depth that these hormones really play in our body and a lot of the long-term consequences that can happen if we're not supporting these more optimal hormone levels and not taking care of ourselves, and why some of these shifts are happening during perimenopause, even like postmenopausal kind of state, like what is actually going on. I also want to talk about and help with, once again, education, knowledge is power. If you are going to go on HRT, on BHRT, so hormone replacement therapy, bioidentical hormone replacement therapy, why we need to look at all three of these hormones and not just estrogen, not just progesterone, not just testosterone. And I'll say most people in this space who are prescribing hormone replacement therapy, progesterone is usually the first, then estrogen and or a combination of those. Testosterone is often left out. And once again, I don't like to name names, but the big council in the Western medical field that just took the black box warning off of estrogen still is not recommending testosterone for women. And so I want to take some time and space for the education piece on why this is a horrible mistake for most women. Now, also keep in mind, everyone is different. I'm working on getting someone who can talk a little bit more about the types of hormone replacement therapy, on testing, on different things like that, with an actual prescribing or licensed practitioner, because that is not our area of expertise. That is not something that we prescribe within our practice. We are not prescribing practitioners. And that doesn't also mean that you need a prescription. There are ways to support this in more natural ways. And I'll tell you from just for me personally, so I'm 36 now, I fully expect to go on hormone replacement therapy. And my goal is to wait until I'm closer to 40 and then start to really do a deep dive into this and I'm working on doing a Dutch test right now to see where my hormone levels are. Plan on doing another one before that happens, as well as looking at some other labs. And I already have a few ideas of who I'm going to go to as far as this is concerned, knowing what I know and seeing the limitations on education from a lot of prescribing physicians. So I will be having someone on hopefully in the next couple months who can talk more about this. I've got a couple people on my list already. So that is already in the works. So let's just go ahead and dive right in here. And I also have a lovely little chart that I referenced in, I think, the previous episode that I'm going to put in the show notes here that looks at the more of the shifts. And I do use AI to help me put ideas together and come up with this. And full disclosure, AI did help me create this chart. And it has been fact checked. I do not just randomly put things into the AI and trust them. We don't use a ton of AI in the practice, and there's a handful of things that we do use it for. Putting together nice little charts like this is one of those things. So we are going to attach that to the show notes so you can get a better idea visually. I know for me, I'm a visual person of what the shifts in hormones really look like kind of over time. Now, once again, every body is different, every person is different, every woman is different, and our hormones are all going to look different throughout this stage. And there are many factors that go into this, but this is, I think, a good general visual representation of what this often looks like. So let's talk about estrogen here first. So estrogen, and I'm going to break this down into not only the hormones, but then what they do for different parts of our body. So I'm going to start with brain, cognition, and mood. So estrogen does a variety of things in this arena. So the first thing that estrogen does is estrogen plays a role with serotonin, dopamine, and GABA, which are neurotransmitters. So think mood stability. Think about an aspect of motivation. There's an aspect of calming with this as well. Although I would argue that progesterone is more of the typical quote unquote calming hormone when we look at this, and we'll get into that here after estrogen. Estrogen also plays a role with the hippocampus in our brain with memory formation. So you're already going to start to see how some of these things start to be impacted as estrogen first starts to be on a roller coaster and then ultimately declines. It also plays a role in our prefrontal cortex, which has a lot to do with executive function. So if you already have executive dysfunction, if you have ADD, ADHD, when estrogen starts to drop, those symptoms are already going to be exacerbated. Even if you did have those things before this hormonal shift started, you may start to notice some of these things start to happen, that your executive function may start to decline, that the cognition, memory, recall, all of these things start to decline. And the reality is, and once again, I touched on this last time, ADHD, executive dysfunction, ADHD, these are all very real things. And I do and have seen this on countless numbers of clients that many women are quote unquote diagnosed with one or more of these, we can call them neurodivergency dysfunctions or cognitive dysfunctions or different ways of thinking. By the way, none of these, there's nothing wrong with your brain. And your brain just operates a little bit differently. And we can come up with really good strategies to help support your brain in the way that it works. And by the way, all of our brains work differently. And that should be acknowledged and celebrated because we're all different. So if you are diagnosed, if you are perimenopausal with, once again, ADD, ADHD, executive dysfunction, one, yes, maybe. Two, it might just be hormone related, and your estrogen might be falling enough where you're starting to notice these things, and now you can quote unquote test positive or not test high enough to be diagnosed with one of these things. And once again, some of these things are very real for people, and I do think there is an overdiagnosis, especially in women in their 40s right now with this, and they're put on medications that, is this medication really necessary, or would hormone support actually be more beneficial? Really depends on the person. I don't think there's a right or wrong answer. I think it very much depends on the person. It also does a lot with our temperature control center within our brain, which is where the hot flashes, the night sweats really start to happen here. So we're going to see a lot of cognitive issues, brain issues, mood dysfunction type of issues, brain fog, trouble finding words, memory recall issues, anxiety, irritability, and I'm going to put this more in the progesterone category, but sleep issues. Hot flashes, night sweats. All of these things can happen. Now, when we think about the long-term impacts of this, some pretty significant ones. Cognitive aging. And I'll say there's not enough research around many of these topics. And there is some interesting data that we can extrapolate from. When estrogen declines, we know it impacts the brain pretty significantly, as I just shared. Women have a higher risk for memory issues like Alzheimer's and dementia. Do hormones play a role in this? Once again, I don't think there's an answer to this yet. And there is some interesting research around this that I would encourage you, if you're interested in this topic, go to PubMed and you can do some really good research there. But the question is, why is it so much more prevalent in women than men? Are hormones, specifically estrogen, playing a role in this? Once again, there is no answer to this, and I think it's worthwhile to ask. We also know long-term sleep issues can play a big role, especially for women. So does that also play a role in inflammation, in just our cognitive and brain health overall? Can also impact these neurotransmitters, and low serotonin for extended periods of time can really lead to a lot of mood dysregulation issues. The suicide rate among women in perimenopause is astronomically higher than in other female demographic from an age perspective. We also know that the rate of divorce is higher among women, specifically in their 40s and early 50s. I think there's a lot of things at play here, and I do think estrogen is one of those things that are at play here. And once again, because we've been so left out of the research, we don't have enough information on any of this. But once again, if we go back to the physiology of these things, so we know what estrogen does, we know what progesterone and testosterone do, specifically for women and within our bodies, we can make some pretty safe extrapolations and or connections that are very worthwhile, in my opinion, to dive deeper into the research. And the question is, who's going to be doing the research, who's funding it, and what is going to be the outcome of that? And here's the thing. Pharmaceutical companies play a big role in this. And so I do think there's a huge market for pharmaceuticals in the HRT, BHRT perspective, and they're not doing a good job. And the question is, it's a business that is focused around making money. Who is going to have our best interests in mind when it comes to any or all of this? Once again, I don't have any answers to a lot of these questions, and these are just things that I think about a lot when it comes to this and women's health just overall. Okay, so that's the first part of estrogen. The next part of estrogen is around bone health. So estrogen plays a big role in bone health, specifically in three main ways. So there's something called osteoclasts and osteoblasts. And this really looks at bone building and bone breaking down. So estrogen suppresses that breakdown of bone and bone mass, and it supports bone building. So guess what happens when estrogen starts to drop? Those things so the bone building starts to go down, and that suppressing of the bone breakdown starts to increase. So we're getting more bone breakdown, which is why women are so much more prone to osteopenia and osteoporosis. Estrogen also plays a big role in calcium balance. And then we can also, once again, extrapolate that to parathyroid. So we do see a lot of women in perimenopause and postmenopausal women who have calcium issues, who have parathyroid issues, who then often have thyroid issues as a result of all of that. Once again, and then osteopenia, osteoporosis, things like that. So we're really at risk for osteopenia, osteoporosis, and also bone breaking, bone fracture. And I'll tell you from my personal training background, and I don't think I will ever forget this statistic, and it may have changed at this point, but I took a class specifically or certification specifically around the advanced age population and what happens. And the stat that it shared was when you fall and break a hip, as you get older, the chances that that fall is going to end up killing you is astronomically high. And by astronomically high, I mean over 1 million people a year. And this was probably 7 or 8 years ago that I took this course, probably 8. Actually, it might have been 8 or 9 years ago at this point. Can probably guess that number has gone up since then. So the risk of a fall, especially as a female, as you get older, can be very dangerous, not only for that joint and then you might have to have surgery to repair it. Recovery time, you're in the hospital. We know that if you're in a hospital for an extended period of time, the risk for other things like pneumonia, sepsis can also happen. So breaking a bone is not just breaking a bone, or fracturing a bone is not just fracturing a bone. It really leaves us open to a lot of other consequences. And so I think that's really important to understand. And this is why we really talk about, and for me, I mean, a higher protein diet, especially for women, is non-negotiable, especially as we get older. It's non-negotiable. Strength training is non-negotiable for long-term health because this limits some of that. I'll also say that, especially if you're training more in the functional realm from a strength training perspective, that also limits the chances that you're going to fall. It helps support balance, bone density, muscle health, joint health, all of these things, ranges of motion, reaction time, balance. It does so many things for us that we really need to think about. Yes, the estrogen plays a big role, and we also have some other things that can really help and support our bodies as we get older, especially if we don't want to do hormone replacement therapy. Strength training and a higher protein diet are non-negotiable, like 0% non-negotiable, in my opinion, if you want to be healthy long term. So we need to think about these things. Okay, next thing. So estrogen supports muscle protein synthesis. So muscle mass, healthy muscle mass, and muscle building. Mitochondrial efficiency, aka your cellular energy. And I'll tell you, if your cells don't have enough energy, you're not going to have enough energy. Insulin sensitivity. As we get older, we become more insulin sensitive, which means blood sugar dysregulation, which could lead to diabetes, which could lead to a whole host of other issues. Also plays a role in the distribution of body fat. If you're in perimenopause, you know exactly what I'm talking about. One of the questions I always ask from women who come to us and said, I think I'm in perimenopause, and I go, have you noticed any weight or body fat redistribution going on? And the answer is almost always yes, if you are actually in perimenopause. And also maintaining lean body mass, which would be muscle mass. So as estrogen starts to decrease through perimenopause, we become more insulin resistant. That muscle mass starts to decrease. Easier to gain body fat, especially in that abdominal area. And I'm going to talk about the adrenal health too here, because once again, the adrenals are playing a role in this. And I'm going to talk more about this when I get to testosterone and how testosterone is produced, more specifically, where testosterone is produced. And the adrenals play a big role here. And as our adrenals are taking on more responsibility and all of this is a stressor, by the way, yeah, it's very likely that we can get especially that lower belly fat at seemingly overnight. So significant muscle loss, your metabolic rate drops, which means that you may not have changed what you are eating, how much you are eating at all, and your base metabolic rate, the base amount of calories your body needs to survive, is going to start to drop, meaning that even if you're not changing anything, your body doesn't need as many calories. So if it doesn't need as many calories, if you eat the same amount of calories that you have been eating, you're technically in a caloric excess, which means you're going to gain weight. And that's probably going to be in the form of body fat, especially if you're not preventing these things, depending on if you're not eating enough protein, if you're not already strength training, if your base muscle mass is already low, you're coming in at a deficit. And it can take some time to rebuild that. And yes, I still firmly believe at any age, doesn't matter when you start, that this plays a really big role and you can always reverse a lot of this. So this is really important to understand. Okay, so moving on to our cardiovascular system. Estrogen is very protective for our cardiovascular system. Estrogen improves and really we can say stabilizes our lipid health, specifically your HDL and LDL. Go back if you're not familiar with our take on cholesterol. Go take a listen to our blood test part 2 episode and we talk more about it. Cholesterol is neither good nor bad. It is a transport unit. And the two primary things that it transports are hormones and neurotransmitters, which when we're going through perimenopause, both of these things are impacted. And so what happens naturally and should happen naturally is our cholesterol should go up a little bit. This whole under 200 cholesterol nonsense is not accurate when you actually look at the studies. And anytime you're looking at studies, always look at who funded the studies. Who is backing it? Follow the money. It's the advice I always tell our clients when they come to us with questions about new things coming out. Look into the research, but follow the money of all of that research because that is really, really, really important to understand. And not all studies are good. Not all studies are quote unquote accurate in the way that they portray the finding of these studies here. Really important to understand. Okay, so our lipid profile. So estrogen impacts our lipid profile. So when estrogen starts to drop, those lipids are going to start to shift. Now, as women, our cholesterol should increase, should one be higher than men. Naturally, just naturally because we have more hormones to transport, first and foremost. 2, as we get older, our cholesterol is naturally supposed to increase. So if we lower that cholesterol too much artificially, can play a really big role on our hormone health, which is probably already not in a good spot, and our mental and emotional health, which once again already may not be in a great spot based on all of these things. So super important to understand here. It also helps with our blood vessels staying flexible so they can harden, calcification, which can lead to heart issues. Estrogen also supports nitric oxide production. And this was really big in the personal training space many years ago. A lot of people were taking nitric oxide. If you take pre-workouts, there's nitric oxide or something that has nitric oxide in it almost always. Beetroot powder is a big one. Very, very high in nitric oxide. It does quite a few things. One of the things it does is help to transport oxygen throughout our body. It's a pretty important function. It does a variety of other things as well, but that is one of the more important things. Estrogen also lowers inflammation. So we might see as we go into perimenopause and into menopause, Lipids are going to shift. Blood pressure can start to change. Heart palpitations can start. Coronary artery disease, heart attack, cardiovascular disease, arterial stiffness. All of these things can become much higher in women as we age. And keep in mind, once again, go back to one of the previous episodes where I talked about heart attacks, how heart attacks present very, very differently in women, yet physicians are trained to look for the same symptoms in men and women most often. This is a really big deal. Like our cognitive health is one thing, our brain health is one thing, our mental and emotional health is one thing, but we're talking about our cardiovascular system, our heart health, our heart that keeps us alive is one of the most important things that keeps us alive. And estrogen plays a direct role in this. And there was a black box warning on estrogen support up until a couple months ago, despite the research that was out there. Things to think about, just things to think about. Once again, education goes a really long way. Other systems and other areas that can be impacted with decrease in estrogen. So we can call it like pelvic health, urinary health, vaginal health. Vaginal dryness, that's a really big one. UTIs, just changes in our vaginal microbiome can really, some people notice changes in discharge, changes in smell, changes in like BV, the UTIs, the yeast infections. And yes, some of this can absolutely be coming from the gut. And hormones, once again, are playing a really big role here. So all things to really think about. Can also change our pelvic floor. And I'll tell you, most of us as humans have some pelvic floor issues, especially if you have a history of gut issues. If you have a history of bloating, gut issues, constipation issues, I can pretty much guarantee, male or female, you have some pelvic floor issues. This can make them worse. The incontinence, bladder issues, just if you've had children, you may already have some of these symptoms. If you jump or sneeze or cough and you pee a little bit, like pee yourself a little bit, not normal. Common, not normal. It's your pelvic floor that's playing a role in this. And this, even for women who have not had children, these symptoms can become more apparent or start to pop up as we age. And it's because of the estrogen decline. Skin, collagen loss estrogen plays a big role in collagen. You also might, like the crepey skin, thin, dry, increase in wrinkles, all of that stuff can play a big role. Once again, estrogen plays a big role in all of this. It also plays a big role in our immune system. It is not uncommon for women in perimenopause and or postmenopausal women to develop autoimmune diseases, and for those to be found during this time period. There is an increased risk of these things popping up because of the decreased estrogen. So our immune system, the immune modulating properties go down. So our immune system has a little bit of a harder time. Once again, if we couple this with stress, with gut issues, with other things going on, this can put us in not a great place, especially if you already have a history of some of these things. And going over the last few years here, estrogen plays a role also in our immune system in managing inflammatory cytokine activity. If you're not familiar with this word cytokine, do some research on the virus, do some real basic research on the virus that came out in 2020. There are some thoughts in the holistic health space that, long COVID, what really is long COVID? And we have, from my perspective, we work with a lot of clients with long COVID. Sometimes it is long COVID, sometimes it's just other things going on that present similarly as long COVID. And women who are in perimenopause or postmenopausal may have a higher risk because of the role of estrogen in our immune system, in inflammation, in our cytokine activity. This can lead to getting sick a lot, the autoimmune diseases, chronic viral issues. There's a whole lot of things that can be exacerbated during this time period because of our lowered hormone production, specifically with estrogen. So we need to think about all of these things when it comes to any, when someone comes to us, when a female comes to us, and, we could say even in someone in their 30s, but definitely someone in their 40s or 50s, when we're seeing any of these things come up, 100% hormones are always in the back of our mind. Sometimes they're in the forefront. At the very least, they're in the back of our mind as something that we need to pay attention to. Now, we need to pay attention to hormones, but also all the things that impact hormones. And usually we're going to start with us, at least in our practice, we're going to start with the other things that impact your hormones and then move into hormone support directly. Because if there are things that are going on that impact your hormones, well, those have to come first before we can do direct hormone support often. Otherwise, we're chasing your hormonal symptoms and they're never really going to regulate or balance themselves out. Okay, so that is estrogen. Moving on to progesterone. So progesterone plays a big role. I'm going to start with I'll start with GABA receptors, but I'm really going to talk about stress response overall here. So progesterone is calming, has an anti-anxiety effect, helps improve sleep, specifically deep sleep, helps to stabilize mood, and we can say buffers the stress response, but also understand that cortisol, which is a stress hormone, and progesterone don't play nicely together. They move in opposite directions. So when progesterone starts to decline, all of these things can start to play a role here. So we may notice sleep disruption. Anxiety starts to really go up, and you have way less of a stress response or stress capacity. We can say stress tolerance, stress capacity. Progesterone, once again, is the first thing that starts to decline. And it can be a steady decline, could also be a pretty quick decline. So we need to understand that. Couple other things here, and I'm going to pull in a couple other types of hormonal, we can say imbalances or issues that come up here. It does a lot with our uterine lining. So if you have brown blood, if you're still having a period and you have brown blood before or at the end of your period, likely there's a progesterone issue. It also plays a role in preventing excess endometrial growth. Think endometriosis. So when we look at endometriosis, there's no cure. They can do surgery. They're probably going to put you on birth control. But are they actually looking at your progesterone and estrogen levels, and specifically the balance between those two hormones? Probably not. Also regulates a lot of the timing and flow of the menstrual cycle, reduces inflammation, and helps prevent cramping. So if someone has a lot of inflammation, a lot of cramping, probably a progesterone issue. Okay, so what does this mean? So this means as progesterone starts to go down, baseline inflammation automatically goes up. There's also a heightened risk of autoimmunity or autoimmunity flares in susceptible individuals. We already know women are higher and more prone to autoimmunity. It's a big deal. It also plays a big role, progesterone plays a big role in just the immune modulating process overall. So if we combine the decline in estrogen and the decline in progesterone, our immune system and inflammation can be a little all over the place. Okay. Progesterone also plays a role as a mild diuretic. Estrogen, on the other hand, can contribute to water retention. If you've ever noticed before your period, start to feel a little puffy from water retention, probably a mild imbalance between estrogen and progesterone, because progesterone is that mild diuretic. So when estrogen starts to decline, we may just start to feel puffier. That's a big thing for a lot of people. And it may not be body fat, it may be excess water. It also supports what we would call vascular relaxation. Once again, if we look at cardiovascular health, hormones play a really big role. Progesterone also, in addition to estrogen, helps to regulate blood pressure. So we're seeing a lot of things here that play a big, big role for our health that no one talks about to us. It also is a vascular calming effect. So we may have greater vascular stress going on. That blood pressure really, once again, can really start to go all over the place for a lot of women in their 40s and into their 50s. And it's like, why all of a sudden? Well, it's probably hormone, at least in part, hormone driven. So why are we not looking at hormones? Why are we just looking at these things overall? I'll also say minerals play a really big role in all of this. And minerals play a really big role in our overall health. And that plays a really big role. Okay. Couple other things that progesterone does and how this can start to look for women as we go through perimenopause. And some of these are just kind of one-off here. So progesterone helps to limit estrogen-driven breast cell proliferation, which it's not the only thing, can play a role in breast cancer. Once again, there are estrogen-driven breast cancers out there. And if we look at why, and once again, I have someone in mind that I've already reached out to talk more about cancer, root causes of cancer, and breast cancer, especially estrogen-driven breast cancer, is one I really want to talk about because I think this is really important for us to understand. This can play a role. It's not the only thing, and it can be one thing. Why are we not looking at progesterone levels? Why are we not looking at estrogen metabolism and how estrogen is metabolized even before this happens? In women who may have a family history of estrogen-driven breast cancers, why are we not looking at estrogen metabolism? Why are we not consistently looking at estrogen to progesterone ratios? Because we know this plays a big role with this. Bone health. Estrogen and progesterone work very closely in the bone building process and bone formation process. So progesterone also plays a role in the bone breaking down osteopenia, osteoporosis aspects of things. And we may see even more accelerated bone loss with the progesterone combined with the lowered estrogen levels. So some things to think about here. Progesterone also plays a role in our thyroid hormone sensitivity. A lot of women, especially women who go to naturopathic doctors, are now being put on thyroid medication, sometimes without testing. Even sometimes with very, very optimal level thyroid numbers, they're being put on thyroid meds. I think in some cases this is appropriate. I think in many cases it is not. Because is this just a progesterone issue, and do we just need to support progesterone levels versus putting someone on a thyroid medication, which can have long-term impacts, and for some people it can be very challenging to come off of. So are we putting someone on medication that they don't actually need that can then contribute to them having to stay on that long term? Progesterone also plays a role in blood sugar and insulin sensitivity and we'll say stabilization. So this can further exacerbate insulin sensitivity, blood sugar dysregulation issues that can come up here. Progesterone is a big deal for the brain, for stress, for inflammation, for the immune system, for neurological impacts, all of these things. And when it suddenly starts to go down for some women, I don't feel like myself, I'm overwhelmed, I'm not sleeping, I'm always anxious, I'm irritable. This can be not a mood issue, but a hormone issue. Progesterone is one of the places we need to look. We also need to look at all three of these things. Progesterone, it's not just a reproductive hormone. Stress, it's a neurosteroid, anti-inflammatory. All of these things are really important. So we need to look at all of these things when it comes to perimenopause as these hormones start to drop. Last but not least, testosterone. So when we look at testosterone is a little bit different than the progesterone and estrogen. Progesterone sometimes slowly starts to drop, sometimes abruptly starts to drop. Estrogen usually is a roller coaster before the steady decline. Testosterone usually just naturally starts to decline with age in men and women. The decline usually starts in your 30s, can happen in your late 20s even. So it is estimated by perimenopause, most of us are losing about 40 to 50% of where our peak levels of testosterone were. This starts to go down faster during perimenopause. And it's the cumulative effect of the loss of testosterone that plays a big role here. So it can play a role, lower testosterone can play a role in motivation, specifically loss of motivation, cognition, like brain fog, reduced confidence. This is a really big one for a lot of women in perimenopause. And we call this, apathy, but I would say almost like emotional flatness. A lot of us we really lose that strong, nurturing, put everyone else before us mentality, attitude, inclination, because it's largely hormone driven. And so we're going to lose some of that and can lose some of that. And testosterone plays a role in all of those. It also reduces muscle mass, strength, which can then lead to additional fat gain, bone density issues, the increase in fat gain around the abdomen. From a more sexual standpoint, lowered libido, lowered interest in sex, just overall, reduced libido, but also our ability to orgasm. And some women may find it more challenging to have sexual satisfaction specifically in perimenopause because of the lower testosterone. And here's the thing. This is important. And some would argue it's not that important. I would argue it is very important. And here's why we know it's important. Because as soon as a male goes to a doctor and says, I'm having trouble getting aroused, I'm having trouble performing, going to completion when it comes to a sexual standpoint, there's like 17 different erectile dysfunction meds out there. They will test testosterone, they will put a male on testosterone, almost no questions asked. Why is female sexual satisfaction not addressed the same? We don't have a medication. We don't have a magic medication, let alone 17 that are out there. We're probably going to be offered an SSRI as a starting point, which can further impede everything when it comes to sexual arousal and satisfaction. Why also is testosterone still not recommended for women? Why? Once again, I don't have any answers for. I mean, I have some thoughts. I'm not going to share all of my thoughts. We can go down some rabbit holes. If you'd really like, if you want to, we could always do an episode on conspiracy theories. I have a ton. I don't buy into all of them, and I'm a big fan of them. And I do think there's a lot of validity in a lot of these. But why? Why is women's sexual health not treated the same? And why is that not supported? Even from a hormone replacement therapy, testosterone is often not recommended, which is wild. I'll also say testosterone plays a big role in our ability to recover from workouts. So especially once again, like as our testosterone starts to drop, even if we are strength training, our recovery time may really start to increase. A lot of that can be due to loss of testosterone. Energy plays a big role in our energy. Just overall stamina, recovery time, and fatigue, which once again, if we're not sleeping as well, and now we have limited ability to handle, even recover from stress because of other hormones, testosterone further exacerbates it. So when we look at testosterone is produced, about a quarter of our testosterone in women is produced in our ovaries. So that is being shut down. About another quarter is produced in our adrenals, which when our adrenals are taking over other hormonal productions, sometimes this can limit our adrenals' ability to produce testosterone itself. Our adrenal health is also, for many, many women entering into perimenopause, already in the trash. And then there's the other 50% is peripheral conversion. So that is where testosterone is really coming from. So when we think about this and we're losing all of this is a really big deal. And why are we not looking at this more? I'll also say that by and large, we don't have good ranges for females when it comes to testosterone, total or free. Why? Probably because we weren't included in studies until the early 90s, or we weren't required to be included in studies. Even quote unquote normal ranges, we know that those are not optimal, let alone optimal for a specific female. Most clinicians are taught not to give women testosterone. And we're given other things. And there's this whole other mental, emotional component that is typically first and foremost thought of when it comes to our health. And that's why SSRIs are given to us first and foremost versus actually doing deeper dives into actual hormone levels, optimal hormone levels, how to even test hormone levels, what are the appropriate times to test hormone levels. Like all of that plays a big role. So last but not least, testosterone, just a couple other big components and parts of us that can really be impacted by this loss of testosterone. Fatigue, this apathy, vitality, even just loss of self. And once again, I think all three of these really play a role in all of this. But this is a really big deal. And, our energy, our drive, our desire, our ambition, the cognition, the sleep, mental and emotional health, like our hormones play such a big role in all of this. And once again, knowledge is power when it comes to all of this. This is a really big deal. I don't have a lot of answers for you generalized answers, because it varies so much person to person. And we need to look at your hormones. And once again, we need to look at all of these things that impact your hormones. Adrenal health, mineral health, gut health, toxin load, thyroid health, like inflammatory markers. All of these things play a big role. And we can know some of this stuff is going to come up in perimenopause into postmenopausal ranges. And there's not a lot of great support for us out there. There are few and far between. There are really good practitioners out there who have a lot of knowledge when it comes to HRT, BHRT. Once again, we work very well in conjunction with those things, and we have partners that we will recommend if someone comes to us and we think that is appropriate and worth exploring, or if someone wants to explore that. We also have a lot of people come to us already on these things, and they haven't noticed quite the shifts that they want. And that's where we need to look at all of these things. We need to look at the hormones for sure. We need to look at hormone pathways, which are often not looked at. This is where a Dutch test, a urine test, really, really comes into play, because it shows us not only the hormones, but the hormone metabolites and the pathways that they take, which provides such valuable information for us. But that also doesn't mean blood testing doesn't have any role. And it is a cheaper way. But once again, timing, what are we testing? When are we testing? Like all of those things, it really matters. And also, where are you in this perimenopausal, premenopausal, perimenopausal, menopausal, postmenopausal stage? Because that all makes a difference in when and how we test, and what are we looking at, and how do we test for that. So I don't have one solid answer for you, because it varies so much person to person. Know that we can help and support with all of these things. And we will look at all of your hormones. We will also look at all of the things that impact your hormones. And we can help give you some answers or give you some other resources to look at. So I'm going to wrap this up, this 3-parter episode. Thanks for bearing with me. And once again, no one teaches us this. And I think education is power. And when you can go in and already have good questions ready, I think that makes a really big difference. And I think the quality of care that you get will be shaped by this. And I'll tell you, if you bring up some of these questions and your practitioner or provider dismisses you, might be time to look for someone else. And unfortunately, you may have to go through a variety of practitioners before you find a good one. That is the reality of the situation out there. And I'll tell you, I mean, even when it comes to autoimmune diseases, most of us have to go to anywhere between, the last stat I think I saw was 8 to 10 different doctors to get a formal diagnosis with an autoimmune disease, which that is wild in and of itself. So it is shifting, it is changing. There are great people out there talking about this, and educate yourself so much. This goes such a long way. Thank you for listening. As always, please like, subscribe, follow. If it resonates, please leave us a 5-star review. It really, really, really means the world to us. As always, reach out to us with any questions or any topic ideas that you'd love for us to dive into. Thank you for listening, and we'll see you next time.